Hello, hello, hello. Again, I am Dawn Grace Jones, and I am your instructor for your healthcare policy management course. I'm a registered nurse, proud registered nurse. I'm also an attorney. And there is information you need to consider for week 6, our chapter 10 of our book. And what's our book? Healthcare Policy Management. Okay, so when we talk about the that chapter, and that is chapter 10. We're talking about the underserved populations. I'm just giving you an overview of what we're talking about. We're talking about the uninsured and underinsured populations of the United States, and that would be the underserved, often population, because there are all sorts of people that fall in these areas, because we're talking about healthcare disparities. We're talking about inequities of the uninsured, underinsured. We're talking about things that don't reach certain populations, um, things that care. We're talking about healthcare, right? And there are people that are actually within the healthcare system. There are questions of whether certain populations, even if they have insurance, are discriminated against. And this may not be in the book, but it's something you need to consider because of their sexual orientation. Is there health care that can really address their issues um, fairly because of their religious beliefs? Um, is the system where it will work with all based on can they get the right care? These are things to think of. And so we're talking about vast populations in the United States and provisions that should be in place to ensure access to health care from the federal government level. Did the federal government get involved to ensure that everybody is given health care? So you have the Affordable Care Act in place to start to address some of this in place so all would receive health care. So we talk about uninsured people, people with no insurance. We're talking about individuals who do not have public or private health insurance, no health insurance. Um, I remember trying to get my brother. My brother had Medicaid. My brother had been in a car accident which left him to be a quadriplegic. And I was fighting for him because he still had his same personality and he had done some things in a facility that once he went into the hospital, they did what they could not to let him back in, right? So I was speaking with the facility, quite frankly, begging them to give him a bed again because he needed a bed. And they said to me that they were at the point that they had to take the uninsured because of their position in the healthcare system. They were the only facility that took uninsured. So other facilities were upset because they wanted and are to take patients with insurance. So this facility had to start to transfer patients with some sort of insurance out. So my brother had Medicaid. They said he has insurance. We can't accept him because of that, Dawn, if that only. We cannot accept him. It was painful to hear, but I understood. They had to take the uninsured, those that had been, it had to go to a facility and they had large numbers with no, and they had no insurance. They were a facility that took patients with no insurance. So they had to clear their beds for these patients. Uninsured. These are usually, they are low income individuals. They have nothing to cover them. Okay. Just understand that. um, they just cannot afford insurance, and their gaps in the public insurance, they fall through. So they don't get coverage. So again, there is the Affordable Care Act that has healthcare insurance exchanges that help to cover many people that were totally uninsured. Medicaid was expanded in some states to pick up some of them, and that decreased the number of uninsured, but there are still many uninsured persons out there. And then you have the underinsured people. And those are those who have high deductibles, high out of pocket expenses relative to their income. So they can't really afford their insurance. I know of a patient that went to have an MRI done that the person really needed, and the person had insurance and was very proud to go to the desk at the facility when the appointment date and time came and said, I have insurance. And I gave the insurance over the phone, and I heard this with my own ears. And they said, "May I have your insurance card and your ID?" And the person gave it. And then the receptionist said to her, "Your insurance is requiring that you pay $1,000 today for you to get this MRI." I was like, wow. Because I was thinking that if the facility billed, most facilities don't even say a person is totally covered. That facility, that billing is much less. Their rate is less. It's like $300, I'm told, for an MRI. And I'm sure it varies different places. But why would they say $1,000 and do this person like this? The lady walked away. So the much needed MRI did not happen. I've seen this type of thing. So I understand underinsured, right? And again, you're talking about the inequities to access of care, right? Avoidable, hopefully. These people get poor quality medical care, and they have a lot of financial burdens. So we need to understand that these things happen to people in the United States every day. And a lot of people fall in these categories. And many of them use the emergency room as their primary care. So they come to the emergency room because, remember, the emergency room cannot turn away people based on insurance, no insurance, uh, religious beliefs, um, your sexual orientation, or anything else. The emergency room has to at least check the person out. So a lot of people use that as and you understand it. And if you work in the emergency room, you're going to find that that's what happens often. They use the emergency room as their primary care um, doctor's office. And so that's some of the stuff you're going to cover in this chapter. And I kind of went beyond what's in the chapter because there are a lot of things that affect our population. There are a lot of underserved people in the population. And as nurses, we need to be aware of that, aware of how, based on our beliefs, or based on the beliefs of the caregivers, often people are overlooked, not properly served. This can happen, and it does. They have problems with those that go to the hospital or who go to the hospital and they don't have insurance. It's a problem because it's against the law, but that's something that has to be addressed at times when they are sent away without even being assessed. And so we have to look at these things and understand that this happens and be a part of what makes it right, be a part of who addresses it, and what we can do, our part, our best, in making sure we treat everybody fairly and we give our best to all, and maybe coming up with ideas of what can be done for people that are uninsured on another level, or underinsured, or underserved for whatever reason. What can be done? what policies can be put in place. When you start to work, you get on those quality committees and you look at what your facility is doing, your system may be doing. You may be that voice of change. Remember, we are advocates for patients and for what's right, and the nurses on the front line. So remember that. And so this chapter is very important. In fact, all of these chapters are important because it's information you need and you can use. You take care, and thank you for the opportunity to speak with you. Bye-bye.